Hi, my name is Haley Ingalls, RN, formerly employed with Samaritan North Lincoln Hospital in Lincoln City, Oregon, which was the site of the trainings and project that I'll be presenting to you today. So let's begin. Okay, my presentation is about hospital education in the pandemic setting, pandemic being COVID-19. So the reason for this project and training was based upon the pandemic state of the country at the time, the lack of knowledge that most providers and staff had regarding COVID-19 and how to care for said patients, and the unpreparedness of both staff and facility alike to handle an influx of critically ill patients. Samaritan North Lincoln Hospital is a critical access hospital on the rural Oregon coast. It's equipped with only 4 ICU beds, and only 2 ICU RNs are on shift at a time. The majority of truly critically ill patients get sent to larger and better equipped hospitals. However, due to the pandemic, all of the larger hospitals were at maximum capacity at that time, meaning that when the surge inevitably was to hit the Oregon coast, North Lincoln would have to host a larger number of critically ill COVID-19 patients. New workflows were needed to allow for maximum level of care on a limited staffing pool, and to allow for key ancillary departments such as laboratory and respiratory therapy to focus on their new heavier workloads. One of the first steps of implementing this training was to send out a pre-assessment survey to gauge the confidence and comfortability that nursing staff in all departments had. The survey asked about comfortability in certain skills, including EKG, proning, ventilator management, and management of arterial lines. The survey also inquired about general knowledge in taking care of COVID-19 positive patients and understanding the pathophysiology of the disease. The final results showed an overwhelming lack of confidence and comfortability felt by nursing staff, and the average answer was a 2.4 out of 10 on a scale of 1 to 10, which you can see in the screen grab at the bottom of the slide there. Of the skills presented, proning, venipuncture, and EKG were those that most felt uncomfortable performing, providing a focal point for development of the training process. Ventilator management and COVID-19 pathophysiology were also top reported weaknesses. You can see these skills and knowledge listed here at the right-hand corner of the slide, and the care staff were to rate themselves from novice to expert, and you can see the results there. The goal of this training was to educate nurses, CNAs, techs, and MAs at both North Lincoln Hospital and the Samaritan-based clinic systems on the basic care of COVID-19 patients prior to the surge occurring in Lincoln County. After training, these care staff should have had an increased level of confidence and been functional in the care of these patients. The deadline for meeting this competency was May 1st, 2020. To measure effectiveness and whether or not the goal was met, a post-assessment survey was sent out to all staff who attended the trainings. This survey was similar in style to the pre-assessment survey sent out in April. For reference, the training was beginning to be developed in mid-April, and as I had previously said, the goal and the deadline was to have this competency met by May of 2020. Prior to attending any training sessions, the staff were required to review a detailed PowerPoint presentation created by Nurse Education. The screen grab of that PowerPoint is the one that you see there on the slide. This PowerPoint outlined the pathophysiology of COVID-19 and treatments involving care of these patients. The staff were to sign an attestation stating that they had read and understood the information prior to attending any classes. In the hospital, a training mannequin was set up accurately and as intricately as possible to allow for realistic demonstrations. During these training sessions, the proning process was explained by the nurse educator and practiced by attendees. A respiratory therapist was in each session to explain the ventilator and the role of the nurse in performing basic ventilator management. The respiratory therapist, along with an ICU nurse, also explained arterial line management, including how to accurately level and recalibrate the transducer system, as well as how to safely pull ABGs from the arterial line. Multiple of these in-hospital training sessions were held per day for 2 weeks to allow all staff the opportunity to attend. In addition to the in-hospital training sessions, venipuncture, EKG, and nasopharyngeal swabbing trainings were also held in small groups or individually by appointments for those staff who needed it. The reason for these teachings on these skills specifically was twofold. The first reason being that these skills are generally performed by laboratory and respiratory therapy in the case of EKG, both of which departments needed to outsource some responsibilities in order to balance their new, heavier workloads. The second reason being that these skills were also ones reported by staff as being the ones that they felt least comfortable in performing. As for reception, there was some pushback from staff who would have to come in on their day off and from those who felt that they did not need the education, which unfortunately was expected. Overall, trainings went smoothly and the vast majority of necessary staff attended the training sessions. After the training took place and staff were asked to reevaluate themselves and their comfort levels in caring for COVID-19 patients via post-assessment survey, the average numerical answer on a scale of 1 to 10 was 4.4, or as shown above as 44 on a scale of 1 to 100 or 1 to 50, which is nearly doubled from the pre-assessment score of 2.4. This shows that the trainings were effective and that all staff from all specialties felt more comfortable in caring for the patients with COVID-19. However, although these numbers were vastly improved, they do still demonstrate a neutral, at best, comfort level. So more focused and personalized trainings and/or refreshers may need to be done in the future for those who desire them. In conclusion, the trainings were successful in increasing confidence and scalability, and the utilization of an anonymous survey proved to be an effective tool in obtaining honest results regarding staff's comfortability levels. In the future, these methods could be employed positively when developing trainings and handling new treatments, workflows, or further advancements in hospital care, including the next pandemic. Additionally, Lincoln County did experience a COVID-19 surge during the months of June and July of this year, and staff at North Lincoln Hospital reported feeling adequately prepared and did not feel the need for any further training during that time. That is the end of this presentation. I hope that I could answer all questions about COVID-19 and training in pandemic setting for you. Thank you.